So I'm going to talk this morning about spotting risks and potential opportunities for quality improvement in the ICU, a little bit about modern safety theory and designing quality improvement systems in the ICU setting. So we'll put this in the context of a case. It's 2 p.m, a 20-year-old male hit as a pedestrian versus car. With pre-notification, the trauma team's activated, the emergency theatre's cleared, the initial assessment shows a severe traumatic brain injury, and the imaging supports some particular hemorrhages suggestive of a diffuse axonal injury. The patient proceeds directly to the operating theatre, gets an ICP monitor, and comes down to your ICU. So everything good so far. In the ICU, they receive neuroprotective and supportive care, including, despite the ICPs hovering in the low 20s, no decompression was performed. They received no albumin during their stay, early feeding, moderate glycemic control, and early DVT prophylaxis. The patient has a great outcome. 2 weeks in ICU, talking to the family on discharge and walking unassisted. So it's a high five for high-quality evidence-based care and supported by lots of different studies, all interestingly published in the New England Journal of Medicine. But did things really provide quality care, and was it individualised care? So thinking through the situation, did he actually need the ICP monitor? Are there situations where we could potentially give him albumin that would be safe, particularly later in the course of his illness? And is early feeding a good idea for every patient? So I've sort of highlighted a few things there. And clearly, in some areas, we're lacking available and generalisable evidence. There's either not the studies, or the studies aren't quite applicable to your patients. So it makes it quite hard to generate protocols that are too prescriptive in the setting of ICU. So let's now think about safe care. Did this patient receive safe care? Looking more closely, we have a junior nurse looking after on day 2. The patient's ICP was around 18, and every time care was performed went up to 22. The afternoon ward round swooped by with the following instructions: increased sedation, 20 mils of hypertonic saline, and neurosurgery to be consulted for an EVD. And the junior nurse hasn't used hypertonic saline before, but she's used it in ED, but not used it in ICU. She decides to look on the computer. She looks for the unit protocol, but there's no website for this unit, and the unit doesn't actually have very many protocols. She remembers there's some educational material on the O drive, so she tries to log into the O drive, but her user ID won't get her access to the O drive on the Windows. I'm not sure if people had this situation before. So then she's done it before, so she goes to the cupboard, grabs 3% saline, hangs the 3% saline, and gives the 20 ml bolus as she was instructed to do. However, there's an error. The consultant actually intended it to be 20% saline, and there's a significant undertreatment of this patient's raised intracranial pressure with 3% saline. So there's a number of features that led to problems and potential targets for intervention here. There's experience and supervision, communication issues, and IT access issues. Meanwhile, the consultant's sitting at his desk. The protocol for the neurosurgical care for raised intracranial pressure has been sitting there for the last 2 years. His feeling is that every patient's different. He thinks it's best to individualise care, and therefore it's far easier to sit on the protocol than to produce it. Also, there's obviously long lead times and red tape and lots of consultation required for protocols. Again, the incentive is for individualised care, for ease and for time savings. So the resident comes along. He's come back to write up the hypertonic saline. He's never used it before. He looks on the computer as well. He dials up MIMS and types in saline, 500 hits. Hypertonic, 0 hits. He looks on the therapeutic guidelines. Again, nothing on the therapeutic guidelines. And same on AMH. The poor old resident, he's been working 7 days in a row. They do 12 to 14 hours on a day. He has an hour commute each way and leaves him about 5 or 6 hours sleep a night. So he's fatigued. In the end, he just gives up and writes it up. Anyway, at 3%, 20 ml boluses. The neurosurgeons come in at 7 p.m. They don't even look at the computer. They think it's too difficult to log into the ICU system. They just ask the nurse what's been going on. She says, we've been treating this gentleman's raised his cranial pressure with hypertonic saline. He's had 3 20 ml boluses, and it seems to be ineffective. The ICP is still 21. They say, okay, let's put an EVD in. And a week down the track, the patient gets extubated, gets a sputum plug, needs to be reintubated. At that stage, the resident pulls out the intubation checklist, looks through it, says it out to the nurse, it's read back to them by the nurse. The intubation proceeds very smoothly and everything goes well. But then the following night, the resident is doing the ward round in the evening and notices that the heparin's not on there, the feeding's not on there. They go through their fast hugs checklist and go, yes, every patient should be on this, and diligently write up the heparin and restart the feeds. But they didn't think that of the actual system that they're working in, and they didn't think beyond the checklist to discover that the patient's going to be extubated tomorrow and the ICP monitor is going to come out. Our patient had 2 weeks in ICU. They had 14 chest x-rays, 14 sets of blood tests, and blood gases every 4 hours. A letter arrives 3 months down the track, and it's from the patient's family. The staff rip it open expecting to see a lovely glowing report considering the patient had a great outcome. They're a bit surprised. It talks about an absent neurosurgeon whom they never saw or discussed despite the patient being in with a brain injury. They talk about seeing a different intensivist, each with a different opinion every 4 days. They talk about the fact that they were never able to see the patient because there was endless procedures without explanation about what was happening, why it was necessary, and what the effect, either successful or otherwise, was of the procedure. So here, these are all quality improvement targets that we can look at in ICU, of varying complexity to tackle as well. But the biggest target is one of communication. And when did we last train or do a quality assurance activity on communication? So we might move on now to discussing approaches to designing safety and quality and designing interventions. So we've heard a lot in the first part of this talk about the Systems 1 approach to safety and quality, where we spot the risk, we find the cause, and we prevent recurrence. This involves looking for the risk, either at looking for events, adverse events, safety reporting systems, M&M meetings, looking at indicators, either event rates or more coarse indicators of patient outcome like standardised mortality rates that are published for each ICU by ANZICS. We also look for audits of compliance, either compliance with protocols, compliance with systems, compliance with national safety targets, compliance with Choosing Wisely campaigns. We find a cause through a root cause analysis like this one, and we look for technological factors, human factors or safety culture factors that can be targeted with an intervention. And we prevent recurrence. We design a new protocol. We reduce non-compliance with the protocol, and we decrease the variability of practice. And generally that's done through a process of plan, do, study, act cycle, and this is the model for improvement from the New South Wales Clinical Excellence Commission. But Safety 1 has limitations. It's reliant on adverse events, and these are not necessarily all that common. It relies, modern healthcare is very complex, and it's very difficult to deconstruct it to find the root cause of the malfunction, and frequently there's a number of interdependent variables that contribute to the malfunction. When we design the safety systems, we design them around work as imagined. And like Monica mentioned before, work as imagined with doing your OBS at 6 a.m. isn't how work is always done in practice. Finally, if we're successful with our interventions, it's not necessarily a good thing for the quality assurance campaign, because if you're successful, you have no adverse events, and therefore people lose enthusiasm, people lose funding, and therefore it can go on to grind to a halt. So that's why there's a move in the safety and quality sphere looking at a different method of safety. This is a quote from one of the authors of that system. It's a Safety 1 and Safety 2 system description. So Safety 2 is all about making things go right as often as possible, looking from the complete other perspective. You can see there's obviously lots of opportunities for things to go right and far more than things go wrong. So there's lots of opportunities to study things. It doesn't require an adverse event to start the process. It acknowledges that performance variabilities are both normal and necessary, and sometimes staff do things different ways in different situations because of time constraints, efficiency constraints, and often that will lead to a more effective way and a more efficient way of doing business, and an equally a safe approach. If we want to enhance safety too, we need to enhance, embrace and encourage what makes the system work. And it will provide dividends in terms of productivity and excellence as well. Taking these different approaches and applying to our situation of the raised intracranial pressure and the 3% saline. If we took a safety 1 approach and we looked at what the root cause analysis was, we'd find that the junior nurse wasn't very well supervised, the supervising nurse in the bed adjacent was busy with the Prismaflex machine and wasn't able to provide close supervision, and the junior nurse wasn't well orientated to the practice in that unit. The quality assurance interventions would be focused on error prevention. There'd be a new protocol, every single fluid needs to be double checked. There'd be a directive, no fluids can be hung unless there's a prescription. And there might be another workplace directive that if there's not a supervisor for the junior nurses, the bed's closed. Taking a safety 2 approach to the same problem, we'd study why the current system usually works. Is it because we have really knowledgeable staff, good patient selection for the junior staff, or clear instructions from the medical staff? And our interventions would be targeted on managing this variability in the system when the staffing is short. So this might include things like announcing during periods of high risk that we are in a period of high risk and people need to be careful. It might be different supervision procedures where you have one nurse supervising 2 people rather than 1 person. And it might be identifying during these high-risk periods that we need to look at the high-risk activities predominantly and dedicate more supervision to them and to provide a more thorough and rigorous checklist for those procedures. So 2 different approaches to the same problem. Both have merit and both are used differently depending on the actual situation, the severity of the outcome or the severity of the risk, and also the safety culture of the organisation. I'd just like to finish talking about reporting excellence. So there's a really good talk from Adrian Plunkett, talked at SMAC a couple of years ago about learning from excellence and reporting excellence. And like we use in safety reporting systems about reporting adverse events, they put up an online form for reporting excellence. They reported what they achieved, what department it was, what they thought was excellent. And the dividends to pay from this is improvement via a safety 2 mechanism, identifying efficiencies, and definitely about staff morale and staff becoming comfortable and enjoying being celebrating excellence as part of the department. So on that positive note, I'd just like to finish, and thank you very much.